So they form an arcade so that there will be collateral supply. If there is laceration in the lid, there will be exsanguination because of the sheer number of branches of your artery. But this is also advantageous for reconstruction. There's a a high chance for the graft to take because of the rich vascular supply. So remember this area. Medially, I let you feel this area yesterday. So this is where the supraorbital nerve originates. This is also where the supraorbital artery originates. More medial to the supraorbital notch is the trochlea. The trochlea is where the superior oblique hinges itself before it inserts into the sclera. So this trochlea here is also where the supratrochlear artery is located. There's also a supratrochlear and infratrochlear nerve, which we can also block to increase anesthesia in this location. Okay. So the superficial temporal artery here, the transverse facial artery, are all branches of the external facial artery. Okay. And the angular artery here is very close to the junction of the eyelid and the nose. So this is a very important landmark and one that we should avoid when we're doing lacrimal surgery, which is surgery in the nasolacrimal duct, because this can also cause exsanguination. So in summary, the blood supply of the eyelids arises from two systems. So the first one is the facial system supplied by the external carotid, the one I told you. So these are the terminal branches, the superficial temporal and the angular artery. Then ang second source is the orbital system, which is supplied by the internal carotid artery to the ophthalmic artery and its branches. So two of those belonging to the internal carotid include the lacrimal artery and the supraorbital artery. So this one here and this one here. So here in the maxilla, these are external carotids. Okay. So the venous drainage basically copies the name of its arterial partner. So very quickly lang, they are divided generally into a preseptal and a postseptal system. So the preseptal system, this is anterior the orbital septum. Again, orbital septum is continuous with the periorbita. It is behind the orbicularis oculi and anterior to the levator palpebrae superioris. So the preseptal system will include the angular vein and the superficial temporal vein. The postseptal system, meaning behind the orbital septum, are deeper venous channels. So this includes the orbital veins, the deeper branches of the anterior facial, and of course the big vein that receives the inferior ophthalmic vein, the pterygoid plexus. So the lymphatic system usually accompanies the vein. They are present only in the eyelid but not in the orbit. Yesterday someone mentioned lymphatic system. They're not present within the orbit per se, but they are richly supplied around the eyelid. The two main areas where they drain include the preauricular area and the submandibular area. So in general, if for example you're dealing with eyelid lesions or orbital lesions, you always have to palpate these areas. So the preauricular, the submandibular, but I also include the submental, the anterior cervical in front of the sternocleidomastoid. I also include the posterior auricular as well. And yes. So again, preauricular, postauricular, submandibular, submental, and anterior cervical, and supraclavicular The supraclavicular, of course, here na siya. It's pretty low. So I generally palpate all these areas just in case if we miss out on it, to avoid missing out on anything. So lymphatic channels serve the lateral portions of the eyelid. They drain first into the superficial preauricular nodes and then into deeper cervical nodes. That's why I include the others. So the caruncle, this one here, the fleshy mass that you see in the medial portion of your eye, is a fleshy ovoid structure, but it's rich in goblet cells. So goblet cells produce the third layer of the tear film, which is the mucin. So again, ang tear film, 90% is comprised of water from the lacrimal glands. The meibomian gland produces the lipid layer, which is above the aqueous layer. And then the mucinous layer is produced by the goblet cells. So the mucinous layer is not really an exact layer, but it is described as having interspersed siya in the lower levels, and it interacts with the glycocalyx of the epithelial cells of the cornea. So the cornea, imagine lang ha, it's not shown in this photo. Imagine the surface of the cornea, it has an epithelial layer. It's almost as if it's an epidermis of the skin. Then in this epithelial layer, it interacts with sugar molecules. This is what we call the glycocalyx. No? The sugar molecules, they interact with the mucin from the goblet cell. So it's already mixed in the tears. So the mucin and the glycocalyx, they bind. They are fond of each other, so they will bind together, and then this will cause the spreading of the tear over the cornea. So the purpose of your mucin layer is spreadability or wettability. It makes the area more moist. Okay. So this is the goblet cell is one of the rich sources for your mucin. But in the bulbar conjunctiva, the conjunctiva lining the eyeball itself also has goblet cells. They made a study and they found that most of the goblet cells in the bulbar conjunctiva are located in the medial side, inferomedial side, close to the caruncle. The next structure here is the plica semilunaris. So the plica or the plica semilunaris, this is the filmy structure, a narrow, highly vascular crescent-shaped fold that you notice in the medial conjunctiva lateral to the caruncle. So this is a vestigial structure, and it's reminiscent of the third eyelid of your reptiles. So if you see that thin fold in among snakes and frogs, this is the equivalent in mammals, the plica semilunaris. So it says here it's also rich in goblet cells. So again, we have this is just the Latin version, but we call it the superior punctum and the inferior punctum. So the lacrimal gland again has its own fossa in the frontal bone. The lacrimal sac, sac, also has its fossa in the maxillary bone and the lacrimal bone. So in general, the lacrimal gland is divided into two lobes. We have the orbital portion or the orbital lobe and the palpebral lobe. The orbital lobe and the palpebral lobe are connected to each other by means of these excretory ductules. Okay? So for example, if you have a cancer or what we call adenocarcinoma of the lacrimal gland, it is more often found in the orbital lobe. So every time you have upper lid swelling, and when you do imaging and you confirm that there's a lesion in the lacrimal gland fossa, when you attempt to do a biopsy, you should always aim for the the orbital portion of the lacrimal gland and not the palpebral lobe, because you might have sampling error. Okay, you will miss out on the diagnosis because you sampled the wrong lobe. So by gravity and by blinking, the movement of tears is lateral to inferior, and it exits into the nasolacrimal duct. The lacrimal excretory system is comprised of, again, the superior and inferior punctum. So when I say punctum, they're just the holes. You can check on this when you're looking at the mirror. Then each punctum is connected to a canaliculi. So canaliculi is short for small canals. So we also have a superior canaliculus and an inferior canaliculus. In 10% of the population, you will find that they have a common canaliculus. So imagine before they insert into the sac, you will have a shared tract between the two canaliculi before it enters the sac. But in most cases, they insert into the sac separately. Okay, this portion here is the fundus of the lacrimal sac. This portion here is the lacrimal sac itself. Okay, this is the junction between the sac and the duct. The duct is the longest part of the excretory system. The duct is also divided into two. This is the membranous part of the duct, the sac duct junction, and this is the intraosseous part. So meaning to say this is also already inside bone. So if you try to palpate the medial canthus where the carbuncle is, you can feel part of the lacrimal sac. But if you move your finger slightly downward, you're already at the level of the intraosseous part of the duct. So this portion here, there's no point palpating because all you're feeling is nasal bone already. Okay, so sometimes if we have nasolacrimal duct obstruction, the obstruction is at this level. We want that there's no accumulation of fluids in the sac. So we instruct patients to do lacrimal sac massage. When we do the massage, this is called the Krigler maneuver. But the Krigler maneuver is when you massage downwards. But since there's an obstruction already at the end of the duct, we do a reverse Krigler. We massage here, but we ask them to push the fluid back through the canaliculus and through the punctum. Because if there's accumulation of fluid in the sac and the duct, there's a higher chance for bacterial overgrowth, and it will cause the cryocystitis. So the entire lacrimal sac and duct will be infected, and it can evolve into a cellulitis and later meningitis. So we need to remove the buildup of fluid here by doing the reverse Krigler. And I think I did not miss anything already. So in ophthalmology, we are taught to measure the components. I think I'll show you later na lang. This one, we discussed this earlier. I'm not going to this one. So the punctum is the hole. The canaliculus is the small canal. So we are taught that the canaliculus is divided into two. There's a vertical and horizontal component. In total, the length is 10 millimeters or 1 cm, but the vertical component you see here is only 2 millimeters, and then the horizontal component is 8 millimeters. So similar to the lower canaliculus, 2 millimeters vertical, 8 millimeters horizontal to complete a total length of 10 millimeters. This is the common canaliculus. It enters at one point into the sac, but only seen in 10% of the population. This is the fundus of the sac. This one's the sac itself, nestled in the fossa for the lacrimal sac. This is the sac duct junction. And this is the nasolacrimal duct. interosseous component is right over here. It empties into the inferior meatus. So if you have chronic recurrent rhinosinusitis, if this is chronically inflamed, this is one of the leading causes of nasolacrimal duct obstruction. In the young, especially if the child is less than a year old, there's a membranous structure covering the end of the nasolacrimal duct, and it causes tearing in the child. So this is what we call congenital nasolacrimal duct obstruction. You allow several months to pass because in most cases it can spontaneously resolve and canalize. But when you do Krigler maneuver, when you press on the sac, the intraluminal pressure will force the membrane to burst open. Okay, that's why we encourage also mothers to do Krigler massage. The length of the nasolacrimal duct is also divided by several valves. So we have around 5, but the most common of the 5 are the valve of Rosenmuller, located at the topmost of the duct, and the valve of Hasner at the bottommost. So for your congenital nasolacrimal duct obstruction or congenital NLDO, the obstruction is at the membrane is at the level of the valve of Hasner. So the meatus are these areas, no? You know these. These are the turbinates. So this is the middle turbinate, there's a superior turbinate, and the inferior turbinate. Any questions? Hello? None. Okay, let me end the presentation first. Can you see the video?
Yes, Doc.
So this is an example. This is the cryoendoscope. It's a very small camera that we insert into the punctum and into the canalicular system. So this is like your GPS. It tells you where we are, right? You won't be confused. The video is only 35 seconds long, so try to check. So first we dilate the punctum. So we insert the probe and this is what we see. It's not very good, the image, because this is a very tiny camera. So this is the lumen. So we see this obstruction here, that's the membrane. Then we pierce it open. Then we do an endoscope. We use an endoscope to check under the nose, and we see the end of the camera exiting at the inferior meatus. Okay? So this is both diagnostic and therapeutic. So it tells you what the problem is causing the tearing, but you can also use it to open the canalicular system. So now the conjunctiva. Most of the things that we're discussing today, we've discussed already yesterday. So this is just a quick review. So the green portion, again, is the palpebral conjunctiva. It's the underside of your eyelid. It comes after your tarsal gland. The red part is the forniceal conjunctiva. They're continuous, but when the location changes, the name changes as well. The yellow portion is the bulbar conjunctiva, and of course, the blue portion is the surface of the cornea. So your contact lens ends at the forniceal conjunctiva. So please do not spread the ignorant information that you can have a contact lens that ends up behind the eyeball, because your pharyngeal conjunctiva will stop it from migrating. But if there's a laceration in the pharyngeal conjunctiva and there's an opening, it's not impossible for the contact lens to go behind the eyeball. Okay. Um, so the palpebral conjunctiva begins at the mucocutaneous junction of the eyelid and covers the inner surface of the uh, of the lid. And this area here is firmly attached to the tarsus. So it's impossible to cut through the tarsus without cutting through the palpebral conjunctiva. So in this area, in the red area, the pharyngeal portion, the tissue becomes redundant and freely movable. Okay, it has fibrous elements and elastic tissue here. So even the bulbar conjunctiva, for example, if you have a foreign body that's lodged in the conjunctiva, you will still experience some discomfort. This is because these areas are supplied by the anterior ciliary nerves. Okay. So the innervation is mainly coming from the ophthalmic division, still trigeminal. So the cornea is 1,000 times more sensitive than the conch, but the conch itself is also very sensitive. So before we do any removal, we have to make sure that it's not full thickness so that we don't inadvertently cause the area to open up and leak. And number two, we need to instill topical anesthetic to block the trigeminal innervation of the area. So the main role for the conjunctiva, it's part of the cornea is avascular, so it's basically defenseless. So the conjunctiva is the closest defense of the cornea. It is part of the MALT, or the mucosal lymphatic system, and it's comprised of T and B cells. So they also have memory cells in the underlying epithelium, and they are more concerned on antigen processing. Okay, I think that's all enough for the conjunctiva. This is a histological picture of the conjunctiva. So the arrows the arrows here are showing the basal cuboidal cells. Then eventually, when they go down, they are flattened into polyhedral cells. Okay. I'm not sure if there are any pre-med na med tech here. I think I'm not sure if this is the basal cell are also the goblet cells. So this is a blood vessel here. It's not stroma. So the Tenon's capsule, we're moving inwards now. The Tenon's capsule it's also known as the fascia bulbi. So it's the soft tissue covering the entire eyeball, aside on top of the sclera. So the fascia bulbi, or the Tenon's capsule, is above the sclera but under the conjunctiva. So it's like a middle layer. So it's comprised of elastic connective tissue that fuses posteriorly to the optic nerve sheath and anteriorly with a thin layer of tissue called the intermuscular septum. So remember yesterday we talked about the intermuscular septum, the one that kind of connects the rectus muscle together around the spiral of Tillot. And this is where the fascia bulbi inserts. So roughly 3 millimeters posterior to the limbus. So the Tenon's capsule is the cavity within which the globe moves. It is composed of compact collagen fibers with a few fibroblasts. So the collagen are types 1 and type 3. Types 1 and type 3. Okay. So the Tenon's capsule is thickest in the area of the equator of the globe, and the connection between the Tenon capsule and the periorbital tissue helps suspend the globe inside the orbit. So the extraocular muscles penetrate this connective tissue approximately 10 millimeters posterior to their insertions, and they serve as a sleeve around the muscles, creating pulleys and suspending the eyeball. So at the point where Tenon capsule is pierced by the tendons, it sends the tubular reflection around each of these muscles. And then they also become continuous with the muscle. So just imagine, to make it simpler, the muscles that are firmly attached to the globe at the tendons are encased by fascia bulbi. And the encasement itself, we call it a suspensory ligament. Okay, that's all lang. I don't have to finish na. Tapos the suspensory ligament supports the eyeball. So there are two suspensory ligaments, the Lockwood and Whitnall. So now we will look into the vascular supply of the eye itself. So the ophthalmic artery is the first branch of your internal carotid artery. So the ophthalmic artery branches into several points. So the most important here is the central retinal artery. So the central retinal artery follows the optic nerve and supplies the anterior half of the retina. So if you look at the layer of a cake, the superior layer is the one facing the world, so outside siya. So that's the inner layer of the retina. The back portion of the retina, the one facing the choroid, is the posterior layers. So the central retinal artery supplies the anterior half, so the anterior face. So which vessel supplies the posterior half? It's the choroid, which is comprised of the short posterior ciliary artery. So para lang clearer, I'll describe the layer of the eyeball. So the eyeball, it has tunics. So tunics are clothes, no? So the fibrous tunic is the sclera, the one that you mentioned earlier. The middle tunic is the vascular tunic called the choroid. And the inner tunic is the retina. It is also known as the neural tunic, the extension of the brain. So the retina will coalesce to form the optic nerve, which exits the eye to travel to the brain. Okay, so the middle layer is the vascular layer. It is the choroid. The supply of the choroid comes from the short posterior ciliary artery. So the short posterior ciliary artery will form capillaries wrapping around the eye inside, and that's the choroid. And then the outer layer, of course, is the white layer, the sclera. So the central retinal artery, the one I talked about earlier, supplies the retina, the anterior face, the anterior half. But the posterior half is supplied by the short posterior ciliary, which makes up the choroid. Is this clear? I will show a picture later. I think wala na ako na-include. It's kind of difficult to understand. Let me Google search up photo, ha? Saglit. Yeah. So here. Schematic, I think is good. Do you see the picture of the eye? Hello? Hello?
Yes, Doc.
Okay, so remember the tunics? So I said the fibrous layer is the sclera. The middle layer is the choroid, and then the inner layer or the neural tunic is the retina. So let's talk about the retina first. So the neural tunic or the retina receives light. This is the extension of the central nervous system. So it is a nerve. The retina coalesces to form the optic nerve, and it exits the eyeball to connect to the brain. The retina, if you divide this yellow portion into half, the one facing the world is the inner retinal layer, and the one at the back, the one facing the choroid, is the outer retinal layers. So since the outer retinal layers is next to the choroid supplies food and blood, oxygen, and etc. only to the posterior layer of the retina. So the the inner retinal layers, the supply comes from the central retinal artery. Okay. As you can see here. Okay. Because the central retinal artery travels together with the optic nerve. So see choroid is just short for choriocapillary, comes from the short posterior ciliary artery. Then the choroid is only part of the uvea. The uvea is the collective term for the vascular supply of the eyeball. So it's comprised of the choroid, but if you move anteriorly, it's the choroid is also the ciliary body is also part of the choroid, and the iris, the colored part of our eye, is also part of the ciliary body. So these are the blood vessels inside the eyeball. Okay, so, is it clearer now?
Yes, Doc.
Okay, let's go back. What na- So who supplies the muscle? The long posterior ciliary artery supplies the muscle. So they when they hit the muscle, we call them muscular arteries already. So we have two each for each muscle, no? So each muscle, superior rectus, etc. They have two arteries each, except for the lateral rectus. The lateral rectus only has one. So it's unpaired. So ischemia is higher, is greater if we uh, cut the for the lateral rectus. Ischemia is higher for the lateral rectus if we cut the muscle. So the long posterior ciliary, the muscular arteries also, they after they leave the muscle, the long posterior ciliary artery inserts into the muscle. They're called the muscular artery. But once they exit the muscle, they they change the name na po. So the terminal branches of the muscular arteries also supplies the limbus. Okay? So when we do muscle surgery, like when we fix cross-eyed patients, when we cut the muscle, we we have to limit it to at least to only two muscles or three muscles. More than three muscles that we cut, we can cause anterior segment ischemia. Okay. So of course the venous drainage of the eye follows the eyeball follows the arterial supply. And now we have a clearer picture of the pterygoid plexus here, the one that empties the inferior ophthalmic vein, and the cavernous sinus here. The cavernous sinus at this level is already at the sella turcica. So the sella turcica is where the pituitary gland rests. So this is where the cavernous sinus is as well. So adjacent to this is also the internal carotid artery. Okay. So the superior ophthalmic vein the one you see here that empties into the cavernous sinus, provides the main venous drainage of the orbit. This vein originates in the suprarenasal quadrant of the orbit and extends posteriorly through the superior orbital fissure and into the cavernous. The vortex veins, this is what we see here. The vortex veins are the veins really coming out of the eyeball. There are 4 vortex veins, 4 to 7 vortex veins. So they empty the choroid. Okay, so since the choroid is the capillaries of the short posterior ciliary artery, they should have a venous drainage, and this is what we call the vortex veins. So they are located in each quadrant of the eye. So if you divide the eye into 4, there are 4 quadrants, so 4 to 7 vortex veins. Okay, I think that's everything na for the venous drainage. Okay, let's talk about the eye. I need people to participate. I'm not sure if you're eating or unsa, but give me the function. One person, cornea.
Doc, the cornea directs light rays into the eye and helps focus them on the light-sensitive retina at the back of the eye, providing sharp, clear vision.
Okay, good. So the cornea refracts light together with the tear film and the air-tear interface. So daghan na siya. It's the cornea, but also the tear film on top of it bends light, plus the air on top of the tear. So ang air, the tear, plus the cornea enters into the eye, hits the lens, then the lens provides additional refraction. The aqueous humor in the anterior chamber also bends light, 1 diopter na siya. The vitreous body, this gelatin here surrounding the entire eye behind the lens, also contributes 1 diopter of refraction. Then the goal is to direct the light to the fovea centralis, which is the most sensitive part of the retina. Okay? Next person, what is the function of the aqueous humor?
Nourishment for your cornea, doc, and lens. So it supplies nutrition, doc, for your cornea and your lens.
Okay, so ang aqueous humor is a blood surrogate. So pasabot sa blood surrogate, it acts like a blood but it's not blood. So it comes out of the ciliary body. So the ciliary body, remember, it's part of the uvea. So ang uvea na to again, anyone summarize? Uvea. What are the 3 components of the uveal tract?
Doc, the choroid, the ciliary body, and the iris, doc.
Yes. So remember, that's the blood supply, the middle layer, the vascular tunic. So the choroid ends somewhere here. Then it becomes the ciliary body. Then it becomes the iris here. So the ciliary body, aside from suspending the lens, it also produces the aqueous. So the aqueous is produced by the ciliary body, exits the ciliary body to the posterior chamber, then it exits through the pupil, it goes into the anterior chamber, no, and then it exits the anterior chamber via the trabecular meshwork around the angle of the cornea. So the angle of the cornea is found 360 degrees. So round jud na siya here. The angle is between this junction, the iris insertion and the cornea. So that's where the aqueous exits. So since it's a blood surrogate, it acts like blood. So it brings nutrients, particularly oxygen and glucose. It also removes wastes. It carries some of the neurotransmitters, no? And then it exits. So every minute, the ciliary body produces around 3 to 5 microliters of aqueous. So that should also follow that every minute of production, there should be egress or exit of the aqueous. Otherwise, aqueous will just continue producing and continue revolving inside the eye and increases the pressure within the globe. Next person, what is the function of the pupil? I don't want similar people lang. Please participate. What's the function of the pupil?
Conduct mo to regulate the amount of light that kanang enters the eye.
Very good. And to follow up, what causes constriction? Yesterday we discussed this.
Bright light though.
No, yeah, I know light, pero unsa part of the nervous system?
Parasympathetic though.
Constriction, parasympathetic. Very good. Dilation.
Pathetic.
Okay, sympathetic. Okay. So the pupil is only part of the iris. So the iris is part again of the uveal tract. It's the colored portion of the eye. So in among Asians and blacks, the iris is typically hyperpigmented. It's filled with melanin. So in whites, the lack of melanin showcases the vessels. That's why they appear blue or gray. Okay. Then so where else pa? So the ciliary body next. Another person. What is the function of the ciliary body? Hello?
Doc, it produces fluid in the eye, which is called aqueous humor, Doc.
And what else pa?
It also contains ciliary muscles, which changes the shape of the lens.
So this is what we call accommodation. Okay. So the ciliary body, part of the uveal tract. Pero in the uvea, in the choroid, there's not much muscle. The ciliary body and the iris, they have muscle. So sa iris, the one that regulates the pupil, the opening ang pupil, no? The iris. The one that opens and closes are the radial muscles of the iris. The ciliary body has ciliary muscles that is attached to zonules. So zonules are like puppet strings. The zonules are attached there after onto the lens at the equator. So imagine ang lens, the edge of the lens are the equator. So this is where the zonules insert. So when the muscles contract, the zonules opposite ang action, they relax. So if they're not pulling on the lens becomes fat. So that's increase in spherical power. Ibig sabihin, increase in accommodation. It magnifies images. When the zonules relax, when the muscles relax, the ciliary muscles relax, the zonules contract, they stiffen. So they pull onto the lens, and the lens will decrease in anteroposterior diameter, and then you will lose near vision. So you will see far better. Okay? So accommodation is when you can accommodate, you can see nearer. So that's when the muscles contract. Again, accommodation is the ability of the lens, no, to increase its magnifying power. So it's when the muscles contract, the zonules relax, and then the lens becomes fat because no more tension in the zonules. So when the muscles, baliktad yung action niya eh. When the muscles relax, the zonules stiffen, then they pull on the lens, then the lens becomes thin, and then you lose the accommodative ability, but you can also see near. Okay, I hope that's clear. So, if I may ask someone, which part of the media are the clear structures inside the eye, including the aqueous, no, the tears, the cornea, the lens, the vitreous. Which among the media contributes the highest amount of refractive power? Refraction, by the way, is the ability to bend light. Okay, so just ano to. So which one? Which structure?
Cornea, Doc.
Very good. So typically people would answer unta lens. No, it's not. So it's really the cornea and the tear film that contributes to the highest power, around 40 plus. So ang lens mo 20 lang na siya. Okay? Okay, what is the vitreous? We're moving backwards now. What's the vitreous?
It's a gel-like fluid, Doc, that fills the eye.
Okay, where is it located?
The retina, Doc.
The retina is behind it.
Between the lens and retina.
Between lens.
Yes, okay, so it's between the lens and the retina. So the vitreous body provides form, otherwise the eye would be flat, no? So it's filled with collagen. So the vitreous also has aqueous channels to allow communication between the back part of the eye and the front part of the eye. So there are a lot of aquaporins or aqueous channels sa vitreous. When we age, we have loss of collagen, so the vitreous will start to liquefy and it will collapse, no, onto itself. So imagine a balloon, it will collapse onto itself. The vitreous is attached at 4 points. So the vitreous is most attached to the optic disc, to the macula, to all the vessels, no, the central retinal artery and vein, and to the ora serrata. The ora serrata is where the retina ends. Okay? So the brown part that you see here, that's ciliary body already. The last orange line that you see here, that's the retina. Okay, I hope that's clear. So, again, the vitreous is attached to the ora serrata, to the blood vessels, to the macula, and to the optic disc. So when we age and the vitreous collapses, that's what we call vitreous, ano tawag dyan? PVD, posterior vitreous detachment. So posterior vitreous detachment, it's benign, but sometimes it can cause some bleeding because, again, the vitreous is most attached, firmly attached to the vessels. Sometimes it can cause a macular hole because, again, the vitreous is most attached to the macula. Sometimes it can cause some disc swelling, similar reason. And sometimes it can cause retinal tears at the ora serrata because the vitreous is also attached firmly at the ora serrata. Okay? And lastly, we have the retina. So, I said earlier that the retina is an extension of the CNS. It receives the light. So, what are the main say it na lang. So I'm not gonna ask na lang. The retina has photoreceptor layers, no, but that's not the only layer. The retina has 9 layers, as we will discuss later on. So we're going to magnify this area. So tear film, very quickly, we discussed this. I'm so happy we discussed earlier. Lipid, oil, there, anteriormost. It prevents the evaporation of the water component. Aqueous is the one produced by the... okay, ask na lang question. Aqueous, who produces aqueous?
Ciliary.
Sorry. This aqueous is not aqueous humor. It's part of the tear film. Okay, we're talking about the tear film. Who produced the aqueous component of the tear?
Lacrimal glands.
Yes. Who produces the lipid layer of the tear?
Meibomian glands.
Yes. And who produces the mucin, the green dots that you see floating?
Goblet cells.
Cells. Okay. So this schematic is nice. I didn't know that I have this slide there. So this schematic is good. It demonstrates to you the tear film. So ang oil layer is on top, aqueous layer is the whole thing. The mucin is interspersed between the two layers. But as you can see, closer to the cornea, this is where the mucin is the greatest, because again, the purpose of mucin is hello. I mentioned it earlier. Diba it interacts with the glycocalyx. So what's the purpose of mucin? Anyone guess?
For spreadability of the tears. No?
Yeah, so it wettability, or it spreads the tears over the corneal surface. So these are the epithelial cells, and then they have this mga filaments, no? And the filaments, if you zoom in, each surface of the filament is covered with sugar molecules. Then the sugar molecules, imagine like crystal and sugar there, they interact with the green dots. So it helps spreads the tears. Okay? You have to try to imagine this. Okay? This is how you remember ang purpose niya. Okay, skip na this. We discussed na. Oh, cornea na. So before the retina, I'll skip ha. You know where the retina is, and you know it forms the optic nerve, cranial nerve 2. It goes to the brain. It receives light. It has photoreceptors. I will discuss the retina at depth maybe next meeting na. Cornea. So the cornea is clear. We will end at 7:30, so give me 10 minutes na lang. So the cornea is clear, no? But when you do a cross section of the cornea, you see this structure. So number 1 here is the corneal epithelium. Okay, the corneal epithelium is the one innervated by the nasociliary nerve of your ophthalmic division of trigeminal. So it's V1. So if you hit your cornea, it's very sakit. It's hapdos. It's painful because of this, no? So the if you look later, there will be more pictures, no, describing. Number 2 is the Bowman's layer. So the Bowman's layer is the second layer. It's a thin layer, but it's acellular, no cells. Okay, that's why you see wag lang siya pink line or white line. Then you have the stroma. The stroma is number 3. It's the thickest layer. Okay. And then number 4 is the decimase layer. So the decimase layer, or decimates, is the basement membrane of the 5th layer, which is number 5, which is your endothelium. So number 4 is this like railroad track. Na pink is a basement membrane. It's a true basement membrane. And then the monolayer, the single cell layer here, number 5, is the endothelium. So they say na the Bowman's layer here is the endothelium of the stroma. This one. So imagine this big endothelium is there. The basement membrane has its own basal epithelial basement membrane. Okay. So again, number 1. Okay, come on. I want you to answer. Someone please. Number 1. What's this?
Epithelium daw.
Okay, and it has its own basement membrane. Number 2.
Bowman's
Number 3. Stroma. Number 4. Decimate. Decimase or decimate. So it's the basement membrane of the number 5.
Endothelium.
Good. Let's move on. So let's focus now on the epithelium lang. So we're talking about just this purple structure here. So sa epithelium, I said it has its own basement membrane here. So the basal cells are the progenitor cells. This is the pluripotent. Hindi siya pluripotent. It's already destined to become corneal epithelium. but it's a monolayer, and this is where everything hindi man begin, pero this is where they start lang sa at this layer. Kay they all begin at the limbus. Remember I mentioned yesterday, the limbus has limbal stem cells, and the stem cells are the source of your epithelium. So from the limbus, they move down first. They migrate down to the basal layer, this one that you see here. Then from down, they move up, elevator up. Okay, can you imagine? From the limbus, 360 degrees, they all bury down. Tapos they move from down to up. As they move up, they become flatter and flatter and flatter. So I think the next slide shows it well. So again, the limbal stem cells, they're there and they travel from the limbus, they move to the basal layer. Ito. Ay, can you see the pointer kanina? When I shift to laser pointer, can you see this? The pointer?
Yes.
Okay. Okay, the laser is laggy. So from the limbus here, they all move down to the basal layer, and then from the basal layer, they move up, elevator up. As they go up, they become flat. Let's go back to this slide. So then we have from the basal cells, we have the wing cells. These are transitional cells. And then you have the superficial cells, they're flatter. And the most superficial cells, they have the filaments. So they have the filaments, and each filament, they have the sugar molecules, the glycocalyx. And the glycocalyx interacts with the mucin. So I hope this gives a clear picture of how the tear moves in the cornea. No? Tapos, what are these lines here? These are hemidesmosomes. And as we know, hemidesmosomes and desmosomes, they are communicating channels. So they share information, they share nutrients, they share chismes to these areas. Then this equal signs here, aside the hemidesmosomes, they also have anchoring fibrils. So the epithelium is anchored to the Bowman layer and the stroma via these areas. So imagine each of these equal sign, they're like bolts. They keep the epithelium attached to the stroma. Okay, clear? I'm moving forward now. So why is the cornea clear? Remember, yesterday I posed the question, 5 minutes na lang. I posed the question, the cornea is the cousin of the sclera, but why is the sclera opaque and the cornea is clear? The reason for corneal clarity is the arrangement of the collagen fibrils. So when you look at this, the stroma here and the epithelium here, the arrangement of the cells are very, very, very uniform. Okay? So the reason for corneal clarity is the uniform arrangement of the collagen fibrils. The distance between collagen fibril is equal, so it's homogeneous distance. The diameter of each fibril is equal, no? And it's only 1/2 the wavelength of visible light. That's why we can see, because each collagen is smaller than the light. Half lang siya of light. So in the middle, ang other half, light can go through. Okay? And since they are uniform, when they go in, the incident rays, ang pasabot ani is, incident rays are when the structures are not equal. So when light enters, the light bounces to and from. So this will cause blurring. Incident rays cancel each other because everything is uniform. So when light goes in, it just goes in. It doesn't bounce around because everything is uniform.
Okay.
Okay. So uniformity, basically this is all about uniformity. Uniformity is one of the reasons why the cornea is clear, but there are two more reasons. Number one, aside from uniformity, the cornea is avascular. It doesn't have any blood vessels. Okay, no blood vessels. Ibig sabihin, it keeps the cornea dehydrated. No blood vessels. The cornea is kind of dry. In order for it to maintain its clarity, the cornea should be 70% or less dry. Increase in the hydration status of the cornea makes it blurry or opaque. Okay? So, and then ang third reason is the relative dehydration. We call this detergescence. So, clarity is dependent on uniformity, detergescence or dehydration, and avascularity. Okay? So if I ask in the exam, you give me uniformity, dehydration or detergescence, and avascularity. Do not give me other answers. Huh? Okay. I will not describe na, but collagen 1, 3, 5, and 6 are the composition of your cornea. Collagen type 7 anchors the epithelium to the stroma. Then napajud keratin sulfate, blah, 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 dagan. So keratocytes are the main cellular component of the cornea. So in the stroma, we have keratocytes here. Okay, and then they produce the glycosaminoglycans. So the glycosaminoglycans is the extracellular matrix, the one that fills out the space. So the one that fills out the space, the glycosaminoglycans, ang component sa the kind of GAG is keratin sulfate, 65%. The rest are chondroitin and dermatan. Okay. So now let's go deeper. So after this, the stroma, the stroma is the one that's filled with keratocytes. It's the one that produces the glycosaminoglycans, keratin, dermatan, chondroitin. And it's the thickest part of the cornea. Again, uniform. That's why it's clear. Then now we go to the decimes and the endothelium. The endothelium is a monolayer, single layer lang siya of cells. And decimes is the basement membrane of the endothelium. So the endothelium is energy rich. It has the ATP producing cells. No? So the sodium potassium pumps are found here. So the sodium potassium pumps, they draw water out of the cornea and into the aqueous. Okay? So, ang purpose niya is like it's a dam. It removes fluid from the cornea to maintain the detergescence at 70%. So, please, someone answer, what causes the cornea to become edematous, or where does the water come from attacking the cornea? Hello? Hello?
Conduct eye surgery?
Hindi. Yun lang. I mean, asa ang nearest source of water? What's the nearest source of water that can cause an increase in the percentage of fluid in the cornea, then making it dull?
Ears, doc?
Very good. Sa
Okay.
tears. And aqueous. Very good. So you answered everything na. So aqueous is assaulting the cornea from behind. Tears is are assaulting the cornea from in the front. The one that protects the cornea front is the epithelium. No, that's why if you have epithelial defects, for example, your nail, you scratched your cornea, ang epithelium got removed, you will have blurring of vision, especially if it's in the center, because that area there will be edematous until it will be replaced by new epithelium already. Then also the aqueous is assaulting the cornea from the back. So the responsibility of keeping the cornea at 70% hydration is the job of the endothelium. Okay, it has energy and ATP producing cells that activates the sodium potassium pump. So it draws water out, sodium out, so that fluid will also go out of the cornea and back into the aqueous. Okay? So if we have decimes there, for example, when I do cataract surgery, then I accidentally scratch the decimes membrane and the endothelium along with it, that area will also be edematous unless I put the decimes back. Okay. So when we do This is a specular microscopy. This is how organized the stroma and the endothelium is. No? So this is a healthy endothelium because you see the cells are uniform in size. They're monolayer, they're single layer. And then, yes. And you see here the sodium potassium ATPs, no, the bicarbonate. That's the sodium hydrogen pump. Okay. You're free to take screenshots, I don't mind. So I guess we're 3 minutes na lang before mag 7:30. Well, we're 2 minutes beyond 7:30. I think we'll end here. So the next topic will be the sclera. Okay. So we finished 60. Perfect. 60 out of 97. So we have 37 slides left. I'll reserve this for next Wednesday. Next Wednesday, I will be out of town. So I will do the lecture remotely. So, the date again will be on, what's the date? Hello? 15. 15, huh? 1-5. That's Wednesday, right?
Yes, ma'am.
Okay, so I will do the lecture remotely because I will be, yes, I'll be out of town, Jordana. So please, class representative, please coordinate ahead of time from Jessa so that we'll try to avoid this from happening. And then also for all of our sakes, if for example you don't have ENT lectures ahead, please let me know so early para we can have the lectures early so we can end early also, huh?
Yes, Doc.
Noted, Doc.
Okay, sige. Enjoy your weekend. Bye-bye.
Thank you, Doc. Thank you,
Thank you,
Doc.
Doc.
Thank you.
Good luck.
Thank you.
Thank you, Doc.
Thanks.